Om Sai Ram. I offer my heartfelt gratitude to Bhagwan Sri Sathya Sai Baba and thanks to Sri Sathya Sai Organization UK to give us the opportunity to bring another episode in the ongoing health care awareness series program for our wonderful listener. Today, I'm privileged to introduce you our four wonderful speakers. They are very dedicated to their work, and to save the time, they have given very brief introduction. First speaker is well known to our Sai family, Dr. Nikila Pandya, MD, DCH, FRCP, CH. Dr. Nikila Pandya has been a pediatrician for the last 30 years and feel blessed to work with children. After qualifying in Mumbai, India, Dr. Pandya completed her MD in pediatrics from TN Medical College, Mumbai in 2001. Dr. Pandya completed her MRC PCH and became a fellow of the Royal College of Pediatrics and has since been consultant pediatrician in National Health Service. She has previously worked at the Guy's and the famous Royal Marsden Hospital. Dr. Pandya has a subspecialty interest in pediatric oncology and is the lead for pediatric oncology for the trust. She is committed to teaching and is a senior examiner for Royal College exams. Dr. Pandya feels privileged to have been part of the team on many international medical camps organized by Sri Sathya Sai Organization, which have included Sierra Leone, Malawi, Russia, India, Ukraine, Nepal, and Jordan with Operation Smile. With Swami's grace, Dr. Pandya was awarded Pride of Kent in 2004, a nomination for Woman of Britain in 2005, and a Heroes Award in 2015 from the Kent and Sussex Courier Regional Newspaper. Our second speaker is Dr. Atisha Pandya, a young pediatrician. Dr. Atisha Pandya is a pediatrician in training in Kent. She has developed a personal interest in sleep regulations of a baby, and more importantly, the errors we make with sleep training of our babies. Our third speaker is Catherine Taylor. Catherine Taylor has worked at Maidstone and Tunbridge Wells NHS Trust as a pediatric gastroenterology nurse specialist for the past 8 years. Has a special interest in childhood constipation and have established a successful nurse-led clinic for children with difficult constipation. Our fourth speaker is Carin Swart. Carin qualified as a dietitian in 2000. Since 2004, she has worked in Maidstone Hospital, initially as an adult dietitian. For the past 11 years, Carin has been working with children focusing on gastroenterology, allergy, growth concerns, and restrictive eaters. I am sure our listeners will enjoy the wealth of information these specialists are going to share with you. Sai Ram.
Good evening, everyone, and Sai Ram to everyone. I offer my most humble pranams to the lotus feet of the Divine Doctor. The Department of Paediatrics, Maidstone and Tunbridge Wells Hospital brings to you a garland of problems which agonize parents in the form of a whistle-stop tour. Eat, play, love, breathe, sleep, and be happy. I hand you over to Carin Swart, our dietitian, to tell us about the eat. Thank you, Carin.
Hello everyone, I'm just sharing my screen with you now. Tonight we're going to talk about fussy eaters or restricted eaters, or in other words, parents may say, help, my child does not want to eat. We will be focusing on why are children picky eaters, underlying medical problems that impact on the picky eating or fussy eating of children, the effect on the nutritional status of children with picky eating, and equally important, what not to do, and then some tips on what we can do to help. This is an enormous topic, so I'm hoping just to give you some hints and tips quickly in the 10 minutes that we've got. Please also note that for the purpose of this presentation, we are not talking about ARFID, which is the avoidant and restrictive intake disorder. So why does children become picky eaters? Picky eaters happen in 3 stages. Before pregnancy, what the mother eats and if the mother is smoking affects it, but also issues that is available or come around in early life. Taylor and Emmett showed in a study that even at the age of 2 to 4 weeks, picky eaters has shown problems with feeding. They can have fewer sucks per session, or a different sucking pattern, or even issues with latching on. Colic and reflux is also a very stressful problem for the mother and the baby, and this could link into weaning. You'll often find that babies with reflux has got a very sensitive gag reflex and can show issues with spoon feeding. They may prefer to feed themselves. The late introduction of lumpy foods, that can have a problem on picky eating or with picky eaters, especially if this is introduced after the age of 1 year. A study has also shown that babies who was weaned onto vegetables between 4 and 5 months were less picky than those that were weaned after the age of 6 months. Food allergies can cause problems with picky eating. These children has their whole life been allowed or restricted in what they eat. Now suddenly they have to open up and eat a little bit more. The neophobic phase is a normal physiological phase that happens in children between 12 to 24 months. And this is where children avoiding foods that they don't know or that are foods that are new to them. Often the issues in this phase is that people or mothers or fathers give children the same food over and over again because at least my child will eat these things rather than going hungry. Also important to say the prevalence of picky eaters is equally between boys and girls, and it often peaks at the age of 3 years with up to 15% of babies and toddlers being picky eaters. A meta-analysis of 961 studies have shown that up to 70% of children on the autistic spectrum disorder have got problems with gastrointestinal issues. This can range from constipation, diarrhea, or abdominal pain. Parents will often argue, say, my child is constipated because they don't eat anything. Well, that's true. However, if your child is constipated, they won't eat anything either. It's important to sort out those problems before we start modifying or changing the diet. Again, diarrhea and abdominal pain could be a problem. Often when these toddlers aren't able to voice the pain, could be an issue for them. So it's always worth looking into that. Swallowing problems, have a look. Does the child have enlarged tonsils? Do they have a sore throat? Could that be the reason for their lack of swallowing or willing to try new foods? Please look at their teeth. Dental concerns is something that's on the rise very often, and you'll often find when you look at these children that there is some form of problem with their teeth crumbling or dental erosions or cavities. Focus on the nutritional assessment. It's extremely important to ensure optimal growth in children who are picky eaters. Some studies have shown that children who are picky eaters can be underweight with some growth issues. Other studies have shown that they could be overweight. The plate model that you see here on the screen is what we need to eat every day. This is what we expect our patients to eat and even our toddlers to eat every day. But how realistic is this for a fussy eater? Studies have shown that fussy eaters mostly have low intakes of iron, zinc, selenium, vitamin D and beta carotene. They often lack in protein foods and very often don't eat any or enough fruit and vegetables. It's also very important to note that a lot of picky eaters has got an increased intake of refined sugars. You may also find that some of these picky eaters has got a large intake of milk. This is something that I often try with my patients, and I give this to the parents often to take home with them. So what I expect them to do is to take 3 days and write down every single thing the child is eating in every group. What you may find at the end of 3 days, it shows you which group we are lacking in or which group we are lacking in the most. Often what parents do find surprising is the child is eating from every single food group. They're just eating limited amounts per food group. Important to know the difference between a picky and a fussy eater and a problem feeder. If you look at fussy eaters, they may avoid one food group, they may avoid it due to texture. They will often manage a new food on their plate, and if they go off one food, they're often able to reintroduce it fairly quickly. If you look at your problem feeders, these are children with extensive nutritional problems. They have less than 20 foods in their diet completely. Once food phases out, they very often don't phase back in. These children will gag and vomit at the smell or the sight of food and will often refuse foods due to texture, color, or temperature. It is important to say that if your child fall in the problem feeder group, get them referred to a dietitian or at least a pediatrician as soon as possible. So what not to do? This is as important as what to do. The most important thing I would say is do not force feed your child. Don't hold them down and let them eat. Don't make them sit at the table for endless times. This is going to actually cause the problem to be more of an issue than it is already. Don't let them go hungry. These children has not got the hunger drive that we will have, and they will often do go hungry rather than eating any food whatsoever. Be careful of the pressure that you put on your child. Be careful of your own anxieties or parental anxieties. Often you find this with children with underlying medical problems or children with potential food allergies where the parents had to be anxious before, but now suddenly they have to learn to relax. And then most important, do not bribe your child with food. Don't say things like, if you eat your meal, you can get some pudding. Will you eat this? For those of you that studied the plate so far, you'll see that there is a bug. The most important thing that we can do is to make meal times happy. Make it a happy environment. Often I would say desensitize the child before they even get to the table. Prepare them for the mealtime coming. Sing a song before you get to the table. Explain to the child that we are now going to the table and this is what is expected. When you do get to the table, play a game. Maybe look at some different colors. Maybe spot some different textures on there. Make the meal interesting, arrange the food in different shapes and sizes, maybe make a smiley face with the food there. Often picky eaters, they do not like their food touching each other, so the use of segmented plates may be useful. Excuse me. Another very important 4 or 5 tips that I want to share with you. The first one is limit your meal times. This is depending on age, and I would say 15 to 20 minutes is a good time. Up to 30 minutes, definitely no later. Studies have shown that the longer kids sit, the less the intake will be. And often what you find, the majority of the intake will be in the first 15 to 20 minutes of the meal. Meal times, family meal times, I can't stress that important enough. It is important that the child see what you eat. It is important that they realize we're socializing and they follow your example. Messy play, encourage messy play after dinner, before dinner, maybe during the afternoon with foods. Reward any positive behavior that the child is showing, coming to the table, sitting at the table, having the food near them. Reward any of those things. Do not just reward them when they're eating something that you want them to eat. This is again something that we use very often in practice. Remember the bug on the plate. So what you would do with children is to follow these 10 steps. Introduce the food to them, maybe near the plate or on the plate if they allow it, but do not encourage them to eat them. Gradually work through these steps. Let it be on the plate, let him smell them, touch it with your utensil, then touch it with your hands, move on the list like that. It is important to say that every step here can take a week or maybe a month or even longer than that. Another thing that we often use in practice is something called food chaining. So the example that we've got here is to move from your favorite fish-shaped cracker, move to a different shape, then move to a different flavor. And do not expect a child to go from a cracker right down to broccoli. Go with the same food and just slightly make some changes along the line. As we've said, it will take a very long time for these children to eventually eat or broaden their diet. So it's important to add a multivitamin in the meantime to make sure that you cover all the angles. This is just something that I picked up from one of my clinics to show you how long it will take for a child to broaden their diet. So if you take that, the first column here is what a child ate in 2015. It wasn't until 3-4 years later that his food intake doubled. So just be prepared. It will take a long time, but it will be worth it in the end. Thank you very much. I will hand you over now to Nikki, who will talk to you about play, love, and breathe.
I would like to talk to you about the play, love. So the scope of this talk is unusual normal behaviors, behavior in general for children, allergies and common ones, coughing and breathing issues. So breath holding spells, what are these? These are very frightening spells for parents. The child characteristically cries, holds his breath or her breath, turns blue in the face, loses consciousness, falls to the ground, probably can have a couple of jerks which look like an epileptic fit, be incontinent, and spontaneously this terminates. The whole thing lasts for maybe a minute and the child recovers completely. These do not damage the brain long term and are associated with iron deficiency anemia sometimes and need to be treated. They resolve spontaneously. Reflex anoxic seizures. This is the opposite. Instead of being blue, they turn pale, usually brought on by trauma, sudden pain or surprise. The child loses awareness, falls to the ground, goes very white, very stiff, may have a couple of jerks which resemble a convulsion, and then it recovers completely. The STARS website, STARRS website, is extremely useful for information. Daydreaming, this is very common in children, particularly in school-going children, where parents are worried that this could be absent epilepsy or absent seizures. But characteristically, the child will just switch off and you will keep calling, they will not reply, but when you touch them, they respond immediately. They ignore verbal stimulation. The clues to it are, it lasts for a long time, can last for about 2, 3, 5 minutes, and wait for the touch stimulation before they respond, unlike seizures, which are about 10 to 15 seconds. Toddler taming, coming on to behavior. With toddlers, everything's about here and now. So the management of toddler behavior has to be immediate. You have to be consistent. You can't laugh at one point at their behavior and the next point of behavior try and discipline them for the same behavior. That is not logical to them. The 1, 2, 3 magic works very well. Initially, they will cry, but after that, they will understand by 2. So it's 1, 2, and you kind of slightly firmly raise your voice very gently for the 3. They get worried and they stop. Very often they will catch on that by 2 you mean business. Reinforcement for good behavior. Consider the behavior, not the child. Your child is not a bad child. Don't call him naughty or bad boy or bad girl. Sometimes they will have out of control behavior. And sometimes what is useful is if you've got them used earlier on to a certain song or certain music they enjoy, either before they go to sleep or when they're calm or they like listening to, you can even play that music. Sound is a healing to their tempers as well. When they're rude, you can say, I don't like you speaking rudely like that, but I do like it and I'm very happy if you're polite and say, please. Time out, that's the other one. You can have a naughty step for them where they have to sit and come back when they feel better, when they're not shouting anymore. Not in their room, not in their bed. That is the safe haven for them, and they shouldn't be put as a punishment in their room. Model good behavior. Have good behavior yourself. Don't raise your voice. Don't shout. Don't swear. Children have eyes and ears behind their head, and they respond to everything you do. So you have to be very careful on that. If your child is whinging or whining, just ask nicely, what is bothering you? Are you sad? Are you happy? You can use the happy and sad with them, and then they will tell you. And sometimes it's not illogical that they're upset. It's all about the why, what, when, how. Know what triggers these behaviors. Know what are the buttons pressed when they go off hand, and try and avoid them. And consistent admonishments for them have to be applied for inappropriate behaviors. But no raising your voice, just be very firm. Avoiding and diffusing confrontations. Don't let the argument keep going on and on. Describe the behavior rather than evaluating it. Don't be personal and say they're bad or naughty or bad boy or you're a rude boy. That's personal. And also remove the audience. Do not tell them off in front of others. They also have egos and they feel bad, and that behavior will get worse. Moving on now to allergy. Allergy is a combination of genetics, if you have a strong family history, immunology, your own immune system, and environment. And this is just a hygiene hypothesis, which explains how in the developing world, the large families, exposure to parasites are large, infections are many, the lower rate of antibiotic exposure and microbiological exposures are high. So they have less immune reaction to the body. In the developed world, you have smaller family size, you're always cleaning them, you have less farming exposure, lots of antibiotics, and therefore their immune system go a bit crazy and cause allergies. This is just a slide showing you the atopic march, which is basically how allergies grow into the years. Initially, you can see the eczema, which peaks within the first year and the first few years of life and then gets better. With that also has the allergy to foods, which also gets better in the 5th decade of life. The asthma picks up at about 3 years of age and then gets better. And the rhinitis starts about 6 to 8 years of age and moves on into the late 50s. Eat dirt and be healthy. Now that slide is not to tell you that you can eat anything and get away with it, but also don't be too obsessive about cleaning them all the time. It is okay to have messy play with children. Common food allergies in children. Cow's milk should be differentiated from lactose intolerance. 50 to 60% of the European, all your intestines are red, your face is red, and your bum is red because of constant diarrhea or mucus. That means you have an allergy to some food. Nut allergy is common. Peanut and cashew nut are quite common. They exist. So peanut, when you're allergic to peanut, you can be allergic to sesame. When you're allergic to cashew, cashew and pistachios go together. Walnut and pecan nut go together. Traces of nuts and foods are safe. We do advise parents to give children a lick of peanut butter from the age of about 5 to 6 months, just a little lick, to that their immune systems get used to it and are not allergic later on to peanut. Restaurants and holidays, all the information needed is on Allergy UK website. Eczema and food allergy. Although eczema is associated with food allergy, food allergy is not the cause of eczema. For intolerance, there are no tests. So the tests available in the market of hair testing, etc., or electricity being passed through your skin and finding out what you're allergic to, there is no scientific basis for it with us. Asthma, find out if your baby had bronchiolitis as a baby, and bronchiolitis is an infection of a cough and wheezing before 1 year of age. These children tend to go on later to be baby wheezers. Recurrent episodes of croup in childhood later on can be asthma. Recurrent chestiness, which requires antibiotics, actually they don't. They are actually wheezy episodes. Nocturnal cough, cough at night, cough the first thing on waking up. Cuddly toys in the bed. The cuddly toys contain dust mite, not just the dust mite, but the poo of dust mite, which is allergic to children. So if you want to keep cuddly toys on the bed with the children, make sure you freeze them from time to time so you kill the dust mite. Cough while playing or running. All these are signs and symptoms of asthma, and you should be contacting your GP. Thank you very much.
Now we're just doing a quick chair swap. I'm Atisha, and I'm going to be talking to you about a topic that's very, very close to my heart, which I'm sure is the same for many, many parents, which is sleep and the age-old issue of my child doesn't want to sleep. What do we do? So what I'm going to talk about today is a little bit about neonatal sleep and its importance, wake times, the 4-month sleep regression, sleep training methods, and I will touch briefly on naps as well. So we know that parents generally get quite poor sleep when they have a baby, but for some reason, it's a completely accepted thing. And yes, babies do feed often, so they won't sleep. But when it goes on for a while, so for example, 6 months, it starts to take a toll on not just the baby, the mother, the father, and the entire family unit. And it can really alter that experience of motherhood. So a study showed that night wakings in 6-month-old infants were associated with increased reporting of depressive symptoms in parents. And we know for a fact that sleep is such a big part of your mental health. So if you really crack sleep, you can really enjoy parenthood and have a happy mum, happy baby situation. So it's quite important, although we know that newborns can be quite unpredictable at times. Newborns do love routine, so it's very important to try and establish good sleep habits for newborns. And actually, as adults, we have quite poor sleep habits too. We tend to sleep with lights on, with our screens on. We sometimes work in our bed, and these are habits that we've developed over time. And it's really important with a baby to make sure that you go back to basics. Put your baby in its crib when it's drowsy and not asleep. Babies aren't born with the ability to fall asleep on their own. They need to be taught it. Do not let your baby fall asleep during a feed. Try to avoid rocking your baby to sleep and establish independent sleep habits, because that will help you in the future. Try and ensure that you sleep in a dark room. Make your napping environment bright so that they know the difference between night and day. Babies are not born with the ability to tell night and day, and quite often they tend to reverse cycle. So they feed through the night thinking it's day and vice versa. And it's important to establish those early melatonin cues. So bright lights, a little bit louder, so they know this is daytime. And then they know when it's dark, it's nighttime, and that sleep needs to be longer. White noise has also been shown to help because it can muffle out any extra noises that might wake up the babies. And make sure you establish safe sleeping habits. So sleeping on your back and making sure the room is not too warm or too cool. So how long should a baby be awake? It seems to make sense to think that if you keep a baby up for longer, they will sleep for longer. But that's actually not true and really counterproductive. And this slide demonstrates that actually newborn babies sleep for a lot of time, and they should really only be awake for between 45 to 60 minutes between their naps. And anything longer than that, they risk getting overtired. And when they're overtired, they get quite cranky and they find it very hard to switch off because their brains are just firing. And as you can see, as that goes on and as you get older, sort of 3 to 4 years, you can have about 6 to 8 hours of awake time before your nap. So over time, you learn to stretch out those wake periods, but it's very important to keep to them in the day to make sure your baby has a good sleep habit. Now, so you've sorted it out, your baby has started sleeping. So around 6 to 8 weeks of age, your baby's sleeping longer chunks, it's sleeping the 5 hours, sleeping through the night. Everyone's congratulating you, you feel like you've cracked it. But then something happens called a sleep regression. And this is a horrible, horrible thing. So what is a sleep regression? A sleep regression is a child who was previously sleeping well, who suddenly begins to wake frequently and has trouble going back to sleep or starts fighting sleep in the absence of any illness. So most last between 3 to 6 weeks. They tend to be associated with developmental milestones. They have sudden changes in habits, and it can lead to a lot of sleep deprivation, which is very, very difficult on both the baby, who doesn't really understand what's happening, and the parents. So it's important to ask for help in these times. And the most common sleep regression we come across is something called the 4-month sleep regression. Now, the 4-month sleep regression occurs because your baby sleep and your adult sleep is quite different. So you tend to cycle in and out of sleep cycles as adults, but we don't wake every 45 minutes because we're able to fall back asleep independently on our own. And at 4 months, the baby sleep becomes more adult. And what happens is the baby ends up waking up between the sleep cycles, but we haven't taught them how to fall asleep independently yet. So whatever way they fell asleep initially, whether that was breastfeeding or being carried around, you need to do that again. I mean, the easiest way to describe it is if you fall asleep in your bed and you suddenly wake up in your garden, you're going to find that alarming. And in the same way, if a baby falls asleep on your breast or on your shoulder and they wake up in their cot, they're going to panic because they don't know how they got there because they were not taught to sleep like that. So how do you get your baby to sleep well? most important thing is routine. As human beings, we crave routine. We love it. We like the predictability of it. It makes us feel secure. The same with babies. So the easy routine, you feed your baby, it eats, you play with it, you do an activity, they sleep, and then you have your period of time, which is your time. So you may need to feed more in the daytime to meet their needs if they're going longer stretches at night. Make sure you've got very clear bedtime signals. So a dark room, white noise. Put them down when they're drowsy but awake so they can learn to try and fall asleep on their own. And have very clear signs. So 30 minutes before their bedtime at night, you can do something like food, bath, lotion, put on their pajamas, say a prayer with them, give them a hug, and then put them to bed. And it's very important to say the same phrase every time. So whether that's I love you, God bless you, have a good night, just so they know that when they hear that phrase, they're safe and that is their sleep time. The other thing to note is that it's not very good to keep babies up very late. So people think that if they keep their babies up to 10, 11 and put them to bed when the adults do, they'll sleep in a little bit. But actually, babies kind of go back to sort of beginning of time where we were programmed to wake and sleep with the sun. And babies have that natural instinct. So they have very early bedtimes. As soon as it starts getting dark, normally around 6 p.m., their melatonin starts to rise. And it peaks around 11 and 12, which is when they have their best sleep. And then it starts to lower down around 3 and 4 a.m. And that's why you end up with a lot of babies who wake early. And no matter what you do, they're going to wake early for that period of time because they are programmed, as we were originally, to follow that sort of circadian rhythm. Now, how do you teach your baby to fall asleep on its own? So there are various methods you can use. So from a newborn stage, you can put your baby down drowsy but awake and pat them on their back. So shh and pat. And that kind of motion reminds them of a heartbeat and makes them feel very, very secure and allows them to fall asleep. And then you leave your hand on them for a few minutes so they feel that weight and slowly remove it. And what happens with this method is you'll slowly have to pat them less and less and it will take less time. But this is if you start quite early. If you don't, you can try this method, which is the pick up, put down. So you put your baby down when it's drowsy but awake. And once they start crying, so not fussing or kind of moving around, but crying, you pick them up, you sing to them, you wait till they settle, and then you put them down. And then they'll cry again, and then you pick them up again. And you keep doing this until they fall asleep on their own. And on the first night, you might find you need to pick them up something like 30 times. On the second night, it'll be 20, but usually by the third night, and 3 is often the magic number, you'll find that you have to pick them up maybe once or twice, and they understand and pick up things very quickly. And there's another method, which is FERBA, which is sort of the cry it out method. This is not for everyone, but basically it means you put your baby down in a safe environment, you say your phrase, I love you, God bless you, go to sleep, and then you leave the room. And then you set a timer on your phone. And I recommend setting a timer because when your baby's crying, even 10 seconds seems like an hour, and you wait for 2 minutes. And if your baby has calmed itself down, that's fine. But if they're still crying, you go into the room, you pat them, you wait till they calm down, and then you leave the room again. And then you wait for 5 minutes, and then you wait for 10 minutes. And eventually the whole idea is the amount of time you have to go in goes down and the amount of time they cry for goes down until you get to a stage where you can put your baby down and they'll just fall asleep on their own. So consistency is the key. The average crying time on the first night is anywhere between 45 minutes to 1 hour, which is a long time, but the average time to sleep train is about 4 to 5 days. So it's a really rough week. By the end of that, you should have a baby that can fall asleep independently and won't keep waking up at night. And every time they have a wonder week or hit a new developmental milestone, they may sort of struggle a little bit. So you might need to re-sleep train them, but each time it does get easier. Thank you very much, and Sairam. Okay. And now I'm going to hand you over to Kathy.
Hello, good evening. I'm just going to share my screen. So good evening and thank you for having me. My name's Kathy and I'll be giving you a quick whistle-stop tour of the world of childhood constipation and toileting issues. So just some quick facts. 10% of children are thought to suffer from constipation at any one time. and it's been proven that early intervention does provide the greatest resolution of symptoms. Nurse-led management, if you can find it, has a higher compliance and treatment rate amongst children. And despite all the issues with diet and fluid, which are very important, in some children, medications are the most important ways to manage childhood constipation. So the management, it's important to explain to parents the possible causes of constipation and treatment options. Many parents are very concerned if their child has problems with pooing, that there might be something wrong. In most cases, there is nothing wrong, and it just is needed to explain to these parents what's going on. Show them the Bristol stool chart. This is a chart of different types of poos, and ask the parents to keep a diary. Medications, what have you been prescribed? What's working? How is the child taking it? Do they like it? Are they actually taking it? How do you make it up? And what's your knowledge of this medication? And one of the key things is the importance of sitting regularly on the toilet for 15 to 20 minutes after meals, which is the normal gut peristalsis time, for 5 to 10 minutes, or for your toddlers, 1 minute for every year of age. So if you've got a 2-year-old, it is very difficult to even keep them on the potty for 2 minutes. Ensure your child is sitting in a comfortable position. Many children that I've spoken to have told me of the fear that they have of falling down a toilet. You know, if you have a 2 or 3-year-old child and you're sitting them on a big toilet, it does feel like you might be falling. Make sure their feet are flat on the floor, or use a stool. Use a toilet insert if this makes them feel more comfortable. Make it fun. Tips for making it move: blowing bubbles, whistling, blowing up a balloon, rocking. All these help the movement of the poo. Using books, games, distractions. We talk a lot to children in clinic and say, make up a box. Have a box of things that you only do when you're sitting on the toilet. A book. We say, practice your spellings. And reminders. Use a watch. There's something called a wobble watch, which can set alarms so that the child knows to take themselves to the toilet. These are silent alarms, so very good for school children who don't want their peers to know. Have the Alexa tell them throughout the day at home, time to sit on the toilet. Make it fun. Discuss any treatment or plans with the parent and child. Explain to them what's happening. Use a leaflet. Use a plan of the human body. Show them where the poo goes, what's happening to it, to describe soiling and constipation with the child. So often children don't actually know what's going on, so it's really important to use diagrams to show them. Give parents a written plan, you know, so that they know what they're doing. A lot of parents who come to see me say, I've been to see the GP, but I didn't really understand what they were saying. A written plan works really well. And always ask for a review in a month, you know, go back, say, this is what I'm doing, I think it's working, or I might need to do something slightly different. So I'm just going to talk to you about medications, because so often parents say to me, I've been given these medications, I'm not sure what they do, I don't want my child to become dependent on them. So osmotic laxatives, lactulose and Movicol, these you can be on these, your body doesn't become dependent on them. They just draw fluid from your body to the gut, which softens the poo and increases the bulk. So these children that are having hard poos, a sachet of Movicol can just make it softer. And they can be on Movicol for a long period of time. It doesn't matter. Stimulant laxatives, Senna, bisacodyl, or sodium picosulfate, sometimes called Dulcolax. These stimulate contractions of the muscles in the bowel. So they do actually force the bowel to act against itself. This is really important in children who are holding on to their poo, but should only be used for a short period of time. And some softeners, liquid paraffin, Docusate. Sometimes children have a big poo and it tears their back passage. That frightens them. These can soften the stool and lubricate passage for a short period of time while they get used to sitting on the toilet again. Overflow soiling occurs when a large hard poo gets stuck in the bowel. As the child eats and drinks, the poo starts to move around the bowel, which pushes more poo around this lump, and that leaks out into the child's underwear. The child is usually unaware that this is happening. When children are started on medication for constipation, sometimes it takes a while for this lump to break down, and it can cause the leakage to get worse. Sometimes parents stop the medication because they don't realise that the child is constipated. Unless the blockage is cleared and is kept clear, then this will continue to happen. So The difference between overflow soiling and diarrhea is very, very simple. Overflow is thick, is sticky and paste-like. It is very difficult to wipe. I have parents tell me, the child has accidents all the time. I try to wipe it, but I can't get it off. I use a whole pack of wipes. I have to put them in the shower. This is overflow soiling. This is not diarrhea. It also smells old and bad. The child is generally unaware that it is happening. The parents get angry as they ignore it in their underwear. It is important that if this is happening, you get your child examined to see if they have fecal loading, which is poo stuck in their bowel, because therefore we can treat the blockage. This can be cleared by using medication or sometimes an enema. And once this is cleared, we can establish a good toileting regime and lots of medications going in order to stop the bowel becoming blocked again. Sometimes withholding behaviour occurs in young children who are just starting to be potty trained, or that have had an episode where they have opened their bowels and it has hurt them. This scares children. Also, again, the toilet. They may be scared to go and sit on the toilet. So every time they have a feeling to poo, they don't want to go and sit on this toilet. They become scared and it leads to a cycle of them holding on to their stool. Sometimes if the parent says to the child, go and sit on the toilet, you may see a child that is rigid, that's upright, that is going very red in the face, and parents think that they are straining. This can be the child holding their poo in, standing on their tiptoes, squatting down, running away and hiding behind a sofa. This usually lasts until the urge to pass stool goes away, and then they can go back to playing normally. This is generally not the child trying to open their bowels, but this is trying to hold it in. Just these couple of pictures here. This one on the left in particular shows a child that is trying to hold it in. What's the treatment? So ensure that these stools are soft. There is a reason that they are withholding, and generally it's because they have had an episode of constipation. Once the medication is soft and they're going regularly, they begin to understand that it won't hurt them. They must then be establishing a toileting regime and a reward system. Another common thing that I hear in the clinic, I cannot get my child toilet trained, they will only poo in a nappy. Very normal. So what we do is we do it in phases. Child can have a nappy on to open their bowels, but it can be put on and off in the bathroom when they need to go. The child is encouraged to empty the poo into the toilet and flush it away. There's a very good app that you can get on an iPhone or anything that the child can watch, and it's a story about a poo going to poo land. It talks about the importance of it being flushed away in the toilet. Once this is made into a routine with the child going into the bathroom to have their nappy on, you can move forward by encouraging the child to sit on the toilet in their nappy. And then even cutting a hole in the nappy so that the child is sitting on the toilet in the nappy, but the poo is going into the toilet. Over a period of time, you can progress this to the child sitting without a nappy on the toilet. It is often a battle of wills, but a clear and consistent approach will win. So encopresis, sometimes people talk about, this is actually a rare phenomenon, but it's when a child passes a normal soft stool into their underwear. This is not associated with constipation and is usually more psychological in nature. I do hear of a lot of people saying that their children have this, but a lot of the time it is because their constipation hasn't been diagnosed. So this is rare, constipation is more common. However, it is important that children that are doing this, establishing a toileting regime and a reward system. So toileting regimes, I talk a lot about these. Choose 3 times a day for sits. Set a timer, use distractions. A lot of the time it's good to do it before school and as soon as children come in from school. If you have a school-aged child, obviously if your child is at home, you can do it more regularly. Relax, and again, a box of toys for toilet time. Rewards. Use a reward system that the child is interested in. Sometimes it's not sticker charts. Collect marbles in a jar, beads on a necklace, 2p coins to save up for some sweets. And you can use sticker charts. I'm not saying you can't, but sometimes it's just to think differently. And reward them for sitting on the toilet, not just a poo. A poo on the toilet is sometimes so far for a child. Reward them for doing their sits. Reward them then again, if they do a poo, you can give them an extra reward. Have a realistic aim. 10 marbles and a small reward, 20 marbles and a slightly bigger reward. And rewards do not have to be monetary. Baking a cake at the weekend, having a favourite pizza, a Disney day, taking your child swimming. Lots of books to be found at your local library or bookshops, games to desensitise your child, make it fun, talk about poo. There's lots of useful apps and information. The best one that I said earlier, Poo Goes to Pooland, which is a free app. However, Dr Raj on CBeebies does lots of songs about poo. So my last thing is, if in doubt, get your child checked, give some osmotic laxatives, escalate them. If they are constipated, this will clear them out. If not, this will not do them any harm. There's a very good link there to a YouTube video for parents using osmotic laxatives, the poo nurses. If you Google the poo nurses, it will come up. Many thanks.
Thank you very much, Kathy. That was a really in-depth explanation about a very simple thing, to poo. And if that is difficult for a child, how unhappy they can be. We're ready to take your questions. Thank you for this opportunity.
Sairam, thank you so much to all of our incredibly knowledgeable speakers for that whistle-stop tour through paediatrics. So we've got a few questions that have come through, and perhaps you can decide who might be best to answer it. The first question is from a mum. I would like to know what I can do for having a fussy eater. She's currently on the 25th percentile, and although I'm not too worried, I would like her to try a variety of food, but she refuses being spoon-fed and would rather feed herself. I know that we perhaps briefly touched on this before, but perhaps if I hand that over to our dietitians. Carin.
Hi there, thank you for the question. I completely agree. If you're not worried about the weight, just remember to check the height as well as the weight and make sure that they line up on the centile as much as possible and they're not more than 2 centile spaces away from each other. If a child does not like to be spoon-fed, don't use a spoon. As easy as that. Let them feel the food of their hands. They feel texture with their hands and feel it first before they put it in their mouth. If you come towards them with a spoon and they retract, it tells that you are forcing them to eat things that they don't like. So if they can hear the hand feeding or feeding themselves, let them feed themselves. Have the spoon there so that they can use it if they want to. If they force the spoon on them. Hope that answers the question.
Great, that's really helpful. Thank you. The next question is on behaviour. Do you have any advice on toddler tantrums?
Yes, thank you for that question. Toddlers are big business and they're quite difficult in most times, but they're also very quick to learn and pick up on cues. So what do you do when there's bad behavior? You ignore. You actually ignore them and they turn around and come back to you. Good behavior should be praised all the time and encouraged for the child and praised. You have to be consistent. Also try and find out what triggers the bad behavior. Are they hungry? Are they wet? Do they need a nappy change? Are they sleepy? Are you taking them to Sainsbury's when it's time for bedtime or when they're hungry? So know the cues. Try not to fail with them. Try to ensure that their behavior is not a result of frustration, because toddlers often are frustrated and their behaviors come out. Also help them to understand that you are happy when they're good, and they will start understanding when you're happy and say, it makes me sad when you're shouting, but also acknowledge that they're upset. I know you're upset. I know it's upsetting. And as I said earlier in my talk, it's very important you have a favorite song for them. And all toddlers have favorite songs. It could be head, shoulders, knees, and toes. It can be when you're coming down the mountain. It could be anything. Play that music. You can diffuse the actual meltdown you're having. They get distracted for a moment and then they forget. And then they may come back to it, but then you can distract them again. So distracting them, toddlers' distraction works very early. In the slightly older age group, in the preschoolers, the naughty step, when they understand that they have to go on the naughty step, wait, feel better, and then come back. Supposing you have a toddler tantrum or a meltdown in the aisle of Sainsbury's, you hug them, you bring them to you and say, I know you're upset. try and distract them, and then bring them back. So there are various ways you can do it, but try not to take children out shopping when you know they're tired or sleepy. It's a recipe to fail. Thank you.
Thank you. Maybe those tips might work in adults too. You never know. So next question, perhaps for Kathy, do you recommend any sort of good fruit or vegetables before we go down sort of the laxative route for constipation?
Good evening. Thank you for having me. Yes, obviously lots of different fruits and vegetables for all the young children so that they have a variety of food. Just to say that it's more of a prevention, not a cure. So if your child is constipated, you probably do need to have some laxatives, but to prevent it, so good sources of fibre, apples, vegetables such as avocados, beetroot, carrots, prunes, very good, prune juice, kiwis, beans contain soluble and insoluble fibre, lentils, and also if your child is very, very difficult to get these into, make them into smoothies. If they won't eat a smoothie, then maybe freeze them, make them into ice lollies, see if you can get the fruit and vegetables in that way. And the other thing is lots of water, lots of fluids if you can get them in.
Brilliant, thank you. And on that note, this might also be for you as well. Any advice around potty training? I know you've covered quite a bit in your, your speech already.
So potty training, really, the one thing I would say is consistency is the key, and make it fun from the beginning. So don't expect your child to potty train, in one day. Take the nappy off, let them have a bit of nappy free time, and then put the nappy back on. Extend your nappy free time, and then start relating everything to the bathroom. So if they have a nappy change, do it in the bathroom. Keep all your nappies in the bathroom. If they've done a poo in their nappy, get them to tip it into the toilet and flush it away, so that they know that that's where it goes. A lot of the time they sit on the potty just before the bath. Praise them for anything they do on the potty, but praise them again just for sitting on the potty. Make it fun, reward charts, really well, sing songs. And the other thing is just always be consistent. So if you're going to follow through with something, just try and follow it through all along.
Brilliant, thank you so much. And if anyone has any questions, please pop it onto the YouTube channel and we'll see if we can pick them up and get through them by the end of the session. The next question was around allergy. So I work in primary care. We get lots and lots of questions about allergy from mums. Lots of people want allergy testing and EpiPens. So I just wondered if perhaps you could expand and just take us through the indications of an allergy referral and perhaps when do we issue an EpiPen?
So I'll kind of break your question down into the answers as well. It's a very useful question. Yes, there is a pandemic of allergies, I would say. I think what parents need to know is the EpiPen is reserved for an anaphylactic reaction. Anaphylaxis is when you have a collapse or your respiratory center goes off, or you've got mucosal swelling causing you to have a wheeze and unable to breathe. That is possibly the only indication of an EpiPen. And anaphylaxis can also present as just collapse, like an egg allergy, for example, can just have a little kind of a rash and the baby gets very sleepy and looks very pale. That actually is like shock. Okay, so you don't have the swelling of the lips, but that is shock. So any anaphylaxis, by definition, requires an EpiPen. The other thing is they must realize the EpiPen has a shelf life, and they have to either put it as a reminder on their phone or whatever, but remind themselves it still is valid for 6 months after, but even so, they need to know. I think EpiPens, so EpiPens shouldn't be just doled out easily. The second thing is allergy testing. If they just come with weird and wonderful symptoms where a little bit of crying, a little bit of rash, a little bit of eczema, that does not warrant testing. Testing is when you have hives, and tell them very clearly that allergy testing is to know when the allergies are triggered of what we call an IgE reaction, which is like immunoglobulins, through the immunoglobulins. And that's a different pathway through intolerance. So you can't test intolerances. So most of the references we get are intolerances. I need her tested for this because I think she's intolerant to gluten. I think she's intolerant, she got a bloated tummy with gluten. Doesn't make sense. Okay, so you have to be allergic. And allergy signs are itchiness, hives, running eyes, running nose, scratchiness, all of that is acute allergy. And those can be tested. And those actually, even from the history, they're allergic to it. So yes, they can be tested. They can't be tested for, they can't be tested for every single nut. So if they've been eating a certain nut and they're okay with it, they don't need to be tested on it. If they have an allergy with a particular nut, then that particular nut can get tested. Okay, and that is acute hives or allergies or immediate vomiting, or diarrhea can be immediate as well. And that is often an allergy. That can be picked up. So allergy testing should be reserved for children with definite indications, not intolerances. Intolerances, no allergy testing will pick up, not even the ones which are available commercially. Thank you.
Thank you. And perhaps sort of along the same lines as about asthma. So we often are asked, is my child born with asthma? Or is it something that we can diagnose at a very young age, or what kind of ages are we looking at?
So asthma, so I think the under ones, definitely you will not call it asthma. But if there is a very strong history of allergies in the family, toddler wheeze, and multiple things triggering off this wheeze, not just viruses. Viral-induced wheeze is a different phenomenon, which occurs in the under threes. Every time they get a cold, they wheeze, and then they get better. There are no interval symptoms. There's no coughing at night. There's no coughing early in the morning. There's no coughing on exercise. But you have a multi-trigger wheeze, where it's not just the viruses, but lots of other things which can cause wheezing. This tends to grow into being asthmatic, okay? The trial is you often try them with inhalers for 6 weeks. And that is the preventative. And if it's making a definite change, then as the temperature gets warmer, you can take them off and see what happens. But usually we say after the age of 3, it's pretty definite that this is asthma. And that's because the airways naturally get bigger by 3 years. So if it was just viral-induced wheeze, it would get better by 3 years. Do they grow out of it? Unlikely. But they can grow out of it during seasonal. If it's a seasonal exacerbation, that they can grow out of.
Perfect, thank you. And again, in primary care, we try to do asthma reviews on all of our children at least once a year, if not more than that. What would you recommend for children that are using their emergency inhalers, so their blue salbutamol inhalers, frequently?
So I think that also depends on how often you're prescribing it. If they are using, ideally, when you go on to the preventative inhaler, you should be using the blue inhaler, which is the reliever, Ventolin or salbutamol, very infrequently. If you're using it a lot, it means 2 things. The technique is faulty, or they're actually not complying with the treatment. The commonest cause is non-compliance. So have a look at your prescriptions. How many prescriptions of the salbutamol have they asked for, or the Ventolin have they actually, or the Clinil, which is the beclomethasone inhaler, the steroid inhaler. And if they haven't asked for too many prescriptions and they're just asking for blues, then you've got to start asking questions. Brilliant. Smoking, I think, is the worst thing for children with asthma. And I try and tell the parents, and they always say they smoke outside the house, which then half the country should be smoking outside the house. What I tell them is, this child will develop COPD much earlier than you think they will, passive smokers. And that's the only way I can make them think that they will gland up in oxygen. So you actually give them almost a fear of the respiratory illness in adulthood for them to stop smoking and look for smoking cessation.
Brilliant, thank you. And I think we've got a few on sleep. So if I perhaps hand it over to Dr. Pandya Jr. Do you mind just telling us a little bit about when perhaps we should think about moving child into their own room? Because often they're with maybe parents for a little bit. And then what age should we be considering them sleeping on their own?
No, that is a very good question. And it is so personal. And you might find that it actually varies with the same parents between children. People tend to maybe be a little bit more anxious with their first child. I know I was. So to put it into context, I kept my daughter in my room until 8 months. My son went into his room at about 5 months. I obviously love them both the same, but I just got more confident. And it completely depends on your setup as well. If you have the space, maybe you might feel comfortable letting your child go into their room around 5-6 months. We tend not to recommend putting babies on their own for the first few months, purely because of the SIDS risk and also the factors that babies feed often, so it's quite inconvenient for mums to be able to get up, go to a different room and feed, and you might miss out on those early feed cues as well. So as I said, it completely varies on your setup. If you've got space, then maybe by about 6 months. But if you don't, and you've got a toddler who the baby will end up sharing a room with, and your baby is still waking up every few hours at 6 months of age, you really don't want them disturbing your toddler. So you might want to keep them in for longer. I do want to say that it is possible to sleep train your child while they are in your room. People seem to automatically assume that sleep training means you're weaning them at night, or that they're sleeping independently in their own room, and neither of them is true. All it means is that you're teaching your child to fall back asleep on its own. So yeah, it's not perfect for your child to feed every 45 minutes, but sleep training doesn't mean going cold turkey. It means that you pick certain times and you think, okay, I'm happy feeding my child every 3 hours. I'm really happy with that. That works. I think they need that. And you make the choice that if they wake up those times, you will feed them. But if they wake up in between those times, you implement your sleep training method. In the same way, if your child is in your room, you can still sleep train them. It just means that you might want to move the cot a little bit further away from your bed so they can't sort of sense you, but you're aware of what they're doing. It just make sure that the room is dark and that they can't see you, because if they see you, they're going to get upset.
Brilliant, thank you. And for those mums who potentially might be listening, where can they get a little bit more help or advice from what's available in the community for them?
With regards to sleep?
Mm-hmm.
So there are a lot of Facebook groups, actually. There's one group which I sort of stumbled upon. So quite a lot of the information I've got has been through blogs and groups and sort of people talking to me, called Respectful Sleep Training. There are a number of books as well. I think sleep is such an emotive subject, so not every method will work for anyone. So some parents might think the idea of your child crying to let them go to sleep is horrific. Other parents might not want to carry their child all the time. So there are a number of different books. There's the Sleep Whisperer, there's Gina Ford. There are a lot of different, there's lots available online. If you actually just type into sleep training into Google, you'll find a lot of information. And it's about picking the one that works for you. And if you do have a partner, making sure both of you are sort of on board with it, because it is horrible listening to your child cry and you will question yourself. And if you've got your partner saying, are you sure? Is this a good idea? You're going to immediately back down and say no. And then with regards to everything in this, consistency is key, whether it's to do with eating or whether it's to do with potty training. The same with sleep. You want to be consistent so you'll get successful results.
Thank you so much. And I think that concludes our session today. I'm sorry it's become a little delayed. We had a few technical issues. And thank you to all of you so much for giving up your time and sharing your knowledge and resources with us. Are there anyone want to say anything before we close the session?
I'd like to thank the Sathya Organisation UK and Swami for this wonderful privilege to have joined you today. I certainly have learned a lot from my colleagues, and I learn from them every day, Carin and Karen and Kathy, and it's been a learning experience for all of us to string this together, and from my daughter who I learned to learn sleep from. So thank you so much again, and thank you for this opportunity.
Thank you very much for having us.
Thank you very much.